Well, welcome everybody. Good morning. I'm really excited. This is a fun part of the year when our sub-Is get to give a talk and we get to find out a little more about them in the short 10 minutes, 9 minutes that they have to give the talk. We have 4 today. And so I want to introduce our first speaker, who is Margaret Kelly Hedrick, who comes from Duke University School of Medicine, where Jerry Grant kind of told us about her coming, and she has lived up to expectations. She went to McGill. She's a local product, went to Mercer High, but McGill University, and majored in cell and molecular biology, and Hopkins for her Master of Bioethics degree, and she has been spending the last few weeks on the neurotrauma service here. So tell us one fun fact about you, Margot.
Yeah, I was trying to think of one. I'm learning to play pickleball. I try to do something that I'm bad at once in a while, which I'm definitely bad at pickleball. So,
well, local, developed in Bainbridge Island, if I remember correctly, if I'm correct. Yeah. All right. Well, thank you. What's that, John Lozier? Or I thought you was something. All right. Well, thank you, Margot. Why don't you launch? Everybody else, please mute.
All right. Well, thank you for that great introduction, Dr. Ellen Bogan. Hi, everyone. I'm excited to talk to you today about neurotrauma, which is one of my main clinical and research interests. I hope in the 10 minutes I have, I can tell you about the what of what I'm interested in research, the how, some of the methods of how I'm interested in studying these things, and some of the why and kind of my backstory of how I got into this. So I'll start with the what. I think most neurosurgeons encounter neurotrauma through the acute care setting, the GSW to the head, page to the recess bay. I actually did some research here at Harborview in college, working on a PTSD prevention program. And as I talked with patients immediately after the acute trauma period, and then in the months following, I realized that for many people, the greatest barriers that they face and the biggest struggles happen after they leave Harborview and go back to where they're from, and kind of all the things that follow. And this sort of showed me the critical portion of neurotrauma that is chronic and long-term care that is so critical to a patient's successful recovery. After college, I went to study public health and bioethics at Hopkins, and I got really interested in what happens to patients before they even reach the hospital in the first place, both during the hyperacute period, as well as before they even get injured. And so today I want to talk about kind of this care continuum. I'm going to highlight some research I've done and 2 points on this continuum. But I think for me, this is helpful to think about both the ways that our patients move through the system and also kind of different points with which research can be done. So I'll start with the acute care of neurotrauma, specifically some TBI work that I've done. So as you all know, TBI starts with a primary insult to the brain, and then cascades down to a whole host of secondary injuries, which affect different organ systems. So the research group I'm a part of kind of studies these downstream effects. And one of the things we worked on this year was looking at non-neurologic organ dysfunction. So about 2/3 of deaths following severe TBI involve extracranial organ dysfunction. And for those people that survive, they have increased disability at 6 months. So one of the projects we worked on was just kind of describing cardiac dysfunction after severe TBI. We did a systematic review and found over a quarter of patients have cardiac dysfunction. So this is a pretty significant and prevalent problem. And it can present a lot of treatment challenges. So looking at another organ system, we've looked at ARDS and TBI and sort of how to manage those patients when lung and brain protective ventilation can sometimes be at odds with each other. So again, this is a prevalent problem. It impacts patient outcomes, and it can be challenging to treat. And so one of the things we sort of thought about is whether underlying mechanisms for both brain injury as well as subsequent organ dysfunction, such as catecholamine surges and sympathetic hyperactivity, may be able to be modulated by treatments that could impact outcomes not only from a neurologic perspective, but also from other organ system perspective. And so some drugs we looked at this year were beta blockers, as well as dexmedetomidine as a sedation agent. And I want to get into some of the methods that I'm interested in using as well. So I really like working with prospective registries and using epidemiologic methods, partly because I studied public health. I've done some work with Track TBI, as well as the Premier database, which is a large health claims database. And I think these are really nice to kind of help describe what is happening in TBI care. I'll just highlight an example here. We published this paper, it's in press right now, using the Track TBI database. You'll see some familiar UW names on here. I think Dr. Temkin's on the line. And so this was looking at beta blocker use following TBI. And the beautiful thing about Track is you get really granular data that has this type of data about beta blockers really hasn't been published before. We're actually able to see exactly when in the acute period patients were exposed to beta blockers, as well as the type of medication they get and the dosing. And again, this is not something that really exists out there in the literature and is important for kind of laying the groundwork for clinical trials to kind of establish what is going on in sort of standard care. Similarly, we have, this is just an example of our looking at sedation choice. And so again, you get this really granular, this is using the Track TBI database, really granular kind of overlap of different sedation agents for different patients. And so I think prospective registries can be really powerful for identifying candidates for experimental trials, as well as establishing kind of clinical equipoise to run those trials. And then after trials can be useful for looking to see if results kind of findings pan out in a more broad population. Some people have argued that prospective registries are not needed anymore with EHR mining of data. And so we wrote a paper, this is in traumatic spinal cord injury registries, but we wrote a paper about how we think there's still a lot of benefits to prospective registries. Christine Park also worked on this paper with me. But in order to have these be impactful, that they need to evolve and include different types of data, as well as EHR data, while still maintaining the kind of reliability and validity of prospective registries. Okay, switching gears a little bit, I'm going to talk about a project on the hyperacute side of things. So this is now talking about traumatic spinal cord injury. And this is a study that we did looking at sort of geographic factors playing into spinal surgery after trauma. So we found that patients who arrived directly to a level 1 trauma center are more likely to get surgery within kind of the critical 24-hour window. Whereas those that arrive by transfer were more likely to have delayed surgery. Perhaps not a very surprising finding, but one of the things I'm interested in is geographic disparities. So we wanted to see if those that were having delayed surgery were just traveling farther or coming from more rural areas. And we found that that's actually not the case. There's quite a few patients that are injured near to a level 1 trauma center and then are somehow under triage, taken to a lower level first, and then transferred subsequently to a level 1 trauma center, which results in delayed surgical care. And so I think this represents kind of an opportunity to improve pre-hospital triaging of neurotrauma. We just submitted a grant to look at this in greater detail with North Carolina as kind of a case study, and have partnered up with some EMS colleagues as well as databases. So that's kind of highlighting 2 points on this continuum. And sort of as I got into this work, I also started to think more about some of the ethical questions that arise along this continuum, having studied bioethics before this. And I'm sure many of you, this gets into kind of the why of why I'm interested in this. Many of you have been faced with similar questions to these probably every day at Harborview about presenting treatment options and prognosticating neurotrauma when it's really difficult to do so accurately. And as we kind of look through the literature, for people that had written about this, I found that there really wasn't much on bioethics and neurosurgery in the literature. So we ended up doing this poster, and then this has been turned into a paper that's under review, kind of mapping the landscape of bioethical issues in neurosurgery, as well as some models for implementation in medical education. And as I started sharing some of this work on Twitter, I found anecdotally a lot of students were reaching out saying they were also interested in this topic. So Annie Trang, who's the medical student at University of Maryland, has been working with me, and we've started a group based on a needs assessment we did, just an informal one on Twitter. We found there's medical students from all over the world kind of interested in these topics, and they really have a need for mentors in this area. And they're interested in working with other residents, faculties, and students. We actually had our first meeting this week on Monday. I was in the OR, but I heard it went great. So I think it's really exciting that there's students that are interested in learning more about this. And next year, I'll be studying this a little bit more formally in a clinical ethics fellowship at Duke. Thank you for listening to my whirlwind of the what, how, and why of my interest in research. I have a huge team behind me I'd like to thank, as well as everyone here for an awesome sub-I month. I've had a great time, and I'm happy to take any questions.
Wonderful. Thank you very much. That was really neat. I thank you, Margot. Questions? We have time for one question. Anything? All right. Without further ado, Max, you ready? Thank you, Margot. Excellent. Max. So Max is coming to us from McGovern Medical School at UT Texas. He is getting his medical degree there. He went to Yale University, where he earned his BS in biomedical engineering, and he got his master's at Tulane in molecular biology. Max, tell us what you're going to talk about here. Now, one fun fact about you.
One fun fact. I set the Texas high school state record in lacrosse for points. Feels like years ago.
And the athletic achievements only get greater as you get older. So when you're my age, you set the world record in points. Yeah, you just forget the real details. That's the great thing about aging. All right, well, wonderful. Thanks, Max. That's great to know. All right.
Thank you. Quick introduction add on. I work in the lab of Dr. Charles Cox down in Houston. He's actually a pediatric surgeon, but is an endowed chair in neurosciences and runs the pediatric regenerative medicine lab and runs a lot of clinical trials related to mononuclear cells and stem cells. And I'll be talking about kind of the next generation of stem cell treatments for traumatic brain injury. And the title is Mechanotransduction, Therapeutic Mesenchymal Stromal Cells for TBI. I do not have any, I'm not making big bucks off of any patents, yet at least, but this work was supported by the AOA Kukine Student Fellowship. So in the Margot gave a great talk on kind of the pathological cascade of TBI. And I know I'm talking to some of the experts on TBI here, so I won't get into too much detail. But once you get to the later stages of a TBI, we have a lot of medical and surgical options for management when it comes to acute TBI. But once you get out to the long-term chronic inflammation state, we have little to no therapies to kind of resolve the states of chronic microglia activation. One of the reasons why Dr. Cox and others have been focusing on MSCs as a possible therapy for TBI is the phenomenon of inflammatory licensing. This phenomenon describes the ability of MSCs to respond to local or systemic inflammation, migrate to an area, and influence the immune cells around them into a more anti-inflammatory state, thereby resolving inflammation. So Dr. Cox has been studying this with naive stem cells for quite some time, showing that PG2 is a very important molecule in this phenomenon. Prostaglandin E2 has the ability to enhance blood-brain barrier integrity after a traumatic brain injury, as well as resolve some of the neuroinflammation. To paint the picture of where this is on the clinical horizon, he's actually wrapped up a phase 1 and 2A trial and recently received some funding for the next phase of work. So this is approaching clinical practice and should be on everybody's horizon or everybody's radar. So if the current generation of MSCs describe a process of harvesting autologous or allogeneic stem cells, expanding them and delivering them to a patient where their stem cells are then exposed to an inflammatory environment, the next generation is focused on having stem cells ready and pre-exposed to some sort of inflammatory or biochemical or biomechanical insult where they're already pre-excited and preconditioned to act on immune effector cells when they're administered. People are exploring multiple avenues of doing this. Possibly the most obvious is using some of the inflammatory cytokines that are upregulated and overexpressed in the event of trauma, TNF alpha, IL-1B. Other avenues are using hypoxic culture conditions, creating a unique metabolic environment to increase activity of the stem cells. And our lab is focusing on using biomechanical stress. Dr. Cox's group, as well as Dr. Pam Wenzel, who's also at UT, have mapped out the mechanism by which this happens. Increased fluid shear stress activates the focal adhesion kinase pathway, which then in turn upregulates expression of molecules like PGE2, which can be a guiding force in the immune sequence. And this has been well published. And this is kind of where I enter the story as a research engineer. I was tasked with turning this known mechanism into a platform that could be used to produce clinical scale conditioned MSCs for therapy. One of the first questions I asked was, what is the best conditioning protocol for producing these MSCs? So we looked at a physiological range of shear stresses to condition the cells. I started out by designing and fabricating a parallel plate bioreactor within a closed loop system. The panel on the top right there shows a miniature bioreactor. The two gray parts on the top are inlet and outlets that were designed using computational fluid dynamics to make sure that the entire plate, as much of the plate as possible, is exposed to the same shear stress so that we know we're testing the shear stress that we intend to. So this is some of the data that we published from this investigation of an optimized mechanotransduction protocol. Again, we see PG2 as one of our potency assay markers. It's something of a dose response that we saw looking at MSCs derived from two different tissues, some from adipose tissue and others from bone marrow derived MSCs. And we see an upregulation of PG2 in response to increasing wall shear stress. Another molecule in our potency assay is IDO, which can influence T cell activity and proliferation post-traumatic brain injury. And again, we saw something of a dose response. The data is not shown here, but at 12-dyne, we saw a moderate decrease in viability and a decrease in the yield of cells, which we deemed too great to use in an optimized protocol. So we focused on 8 dyne per centimeter squared. not to go too far down the genomics rabbit hole here, but on the top panel is a principal component analysis of some RNA-seq data that we used. We ran on bone marrow MSCs and another derivation, Wharton's jelly. Wharton's jelly is from umbilical cords. It's a stem cell rich goo found in umbilical cords around the vessels. And it's a readily available tissue. There's a lot of biobanking going on, and we collaborate with numerous biobanks, so have great access to these stem cells. Principal component analysis separates your RNA-seq output into the greatest axes of variation. So on the x-axis, we see that bone marrow cells are on the right, Wharton's jelly are on the left, are clustered on the left. So this shows that tissue derivation is the greatest axis of variation. On the y-axis, however, we see wall shear stress cells on the top and static cells on the bottom, showing significant variation due to mechanotransduction. On the bottom, we see some of the genes that are upregulated, and I just point out PTGS2, which encodes for the rate-limiting enzyme, and PGE2 synthesis. And then we see HMOX1, which encodes for heme oxygenase 1 and metabolism and degradation of heme, which is important after a TBI event. We also see upregulation of ICAM, which is an adhesion molecule on the surface of stem cells, which allows for cell-to-cell interactions and guiding that immune response, as well as some intriguing novel molecules like metallothioneins, which sequester metal ions, which if you have a massive events of cell lysis in the brain after injury, could be potentially therapeutic, and it hasn't been reported on much. So once we had to have an optimized protocol, we scaled the bioreactor to look at two things. First, we wanted to run some in vivo experiments on a controlled cortical impact rat model to mirror TBI, as well as compare mechanotransduction to cytokine stimulation, which is kind of viewed as the gold standard of in vitro conditioning. We scaled the bioreactor by adding parallel channels. So you can see there's two channels depicted in the schematic. We've used up to 6 channels in a bioreactor. These panels show the comparison of wall shear stress MSCs to naive MSCs that were then exposed to classic inflammatory cytokines, TNF alpha, interferon gamma, IL-1B, or a combo of all three. And it shows that wall shear stress MSCs outperform the cytokine stimulation, as well as retaining some ability to respond to those cytokines, which is interesting. So you could administer the wall shear stress MSCs and still expect some sort of enhancement in their immunomodulatory capacity after administration. We saw this potency increase exhibited by PGE2 and heme oxygenase 1 production. The bottom two panels are from splenocyte co-culture assays. You take the cells from a rat spleen and select the leukocytes, and then co-culture the MSCs with these leukocytes so that you mirror the immune cell interactions expected in vivo. And we see the suppression of TNF alpha to a greater degree with the co-culture with wall shear stress MSCs. But both cells perform pretty similarly in interferon gamma expression, both significantly decreasing expression of interferon gamma. This is some very preliminary data on our in vivo work. On the top right, you see kind of a little bit of a barbaric schematic, but we, in the controlled cortical impact model, you give the rat a controlled bonk on the head, and then 24 hours later, you administer your stem cells, and then 48 hours later, you inject a dye. You measure the extravasation of that dye to get an idea of how well the blood-brain barrier is functioning. With the pictures on the left, you can see quite a bit of extravasation with the controlled cortical impact model, and a attenuation of extravasation with static, and then the greatest degree of blood-brain barrier preservation with the wall shear stress MSCs. And then in the panel on the bottom right, you see something of a dose response with the wall shear stress MSCs having the greatest preservation of the blood-brain barrier. As a last part here, I'll talk about some of the work we've done with cryopreserved mechanotransduced MSCs. So ideally, any therapy that we come up with for TBI would fit into the temporal constraints of acute neurotrauma. So you get paged, somebody's coming in, severe TBI, the HPI, the clinical exam, the imaging all points to a severe TBI. You initiate your first line acute neurotrauma medical or surgical management options, but at the same time, you initiate a protocol for preparation of the mechanotransduced MSCs. You thaw them from your bank and prepare for administration once the patient is stable. This data compares static fresh MSCs to fresh wall shear stress MSCs to thawed wall shear stress MSCs. It shows that PGE2 production and heme oxygenase 1 production is still retained after a freeze-thaw cycle, as well as the ability of the thawed wall shear stress MSCs to suppress TNF alpha production by immune cells. So this is promising work showing that it could fit within a clinical management scheme. Just wrapping up on my contributions, I designed and fabricated scalable mechanotransduction platform and refined the protocol, started to get some preliminary evidence in a controlled cortical impact model. And this work has been featured, included in grants going to NIH, the DoD, and some SBIR grants. I'm going to continue this is about 50% of my research. The other half is with a blood-brain barrier model that's pictured on the right there, which was actually just funded by a large DoD grant to look at TBI and the blood-brain barrier. I'm also interested in looking at some of the other therapeutic arms of mechanotransduced MSCs. So we know that they produce molecules like PGE2 and engage in paracrine signaling and cell-to-cell interactions, but there's evidence that they also start to overproduce small vesicles that can then be taken up by surrounding cells. These are called exosomes, and these can mirror some of the secretion patterns that we've been seeing in our conditioned culture media. So this is another avenue that might be more easier to incorporate into a treatment paradigm. And then it's early on in my career, but research plays a big role in my interest in medicine. And I would like to continue applying for grants, institutional, foundational, and national, and continuing to build up my body of work. So thank you. And these are some of my babies.
All right, fantastic. Questions for soon-to-be Dr. Skiba?
Yeah, I have a question. What's the durability of this mechanically induced increase in immunomodulatory function of these cells? Does it last, and does it last under conditions into which it would be found once induced into a biologic system?
Great question. So we focused on a freeze-thaw cycle, but do these cells retain their changes for some time? We see significant, a lot of our assays go on for 3 to 4 days. So, and we see that the production, the changes in the transcription are quite significant for up to about a week. We haven't looked beyond that. So I don't have an answer saying the effect disappears at some point. I know that the effect is retained over a number of days.
Okay.
This is just getting called from the org. All right, great. Thanks, Max. And Beneath, you're up next. Beneath did his undergraduate work at WashU in St. Louis in biology and neurosciences, a minor in anthropology. He is at Feinberg School of Medicine at Northwestern. And he, fun fact about you, Beneath.
Sure. Thank you for the introduction, Dr. Alan Bogan. So a fun fact about me is that in middle school for about 9 months, I was top 100 in the world in Mario Kart. So probably peaked then, but
Oh, Mario, wow.
Yeah, Mario Kart. Yep.
Wow, that's impressive. Okay.
So my research presentation is about my research year work entitled Local Delivery of Combination Chemotherapy in Meningioma. So briefly, some background. So meningiomas are the most common primary benign intracranial tumor. For decades, the treatment has been maximal safe total resection, as well as adjuvant radiation therapy for more aggressive meningiomas. There remains no standard of care chemotherapy. So with that in mind, our lab screened over 100 FDA-approved anti-cancer drugs with the goal of perhaps repurposing some of these drugs for use in meningioma. So we did a large screening, and some of the in vitro results can be shown, can be seen on the bottom right there. We identified proteasome inhibitors, histone deacetylase inhibitors, or HDACs, and microtubule inhibitors as 3 target drug classes with low IC50s and had good availability for use in vivo experiments. And so in some of the preliminary experiments in our lab, in intracranial meningioma mouse models, we found that when we deliver these drugs systemically through intraperitoneal injections, IP injections, the mice really could not tolerate these drugs well. They lost body weight very fast, and they would often, die in 10, 12 days. And so we really couldn't see much of a treatment effect. We did notice a little bit of tumor killing when we looked at the brains afterwards. So we thought perhaps that these drugs do show a lot of good in vitro efficacy. So how can we perhaps bypass systemic administration of these drugs? Is there a way that we can locally deliver these drugs? And also, can we combine some of these drugs together with different mechanisms and see if they work better than just one? So we developed an experiment where instead of an intracranial model, we used a heterotopic model, specifically in the flank of these mice. And so we injected about 3 million IOM-Lee cells into the flank. And so IOM-Lee is a immortal meningioma cell line. And so we let these cells grow for about 2 weeks in the flanks to about 270 millimeters cubed. And then we randomized the mice into one of 8 groups, a vehicle control group, bortezomib group, romidepsin, or docetaxel, which are 3 drugs from 3 different drug classes that I had mentioned earlier, and then combinations of those drugs. So dual therapies are all 3 together, and we treated for 3 weeks. And so the treatments were direct injections into the flank of these mice. And so it was very much intratumoral. And so we saw a very substantial effect with our results here when we tracked tumor size change over the course of a few weeks. And so as you can see here, when treating with all 3 drugs or with the bortezomib and docetaxel combination, you see quite a difference compared to the vehicle group in terms of how much these tumors grow, with the vehicle going all the way up to a 600% increase and not very much increase in some of the treatment groups. And we saw kind of a graded response here with the triple therapy compared to dual therapies, which were also better than the monotherapies. And so this was a nice result to see. And then when we looked at body mass, we didn't really see any significant differences between the groups over the course of a few weeks compared to vehicle control. And this was very reassuring, as when we did systemic intraperitoneal injections, we really couldn't carry the experiment past 8 to 10 days. We'd have to censor the mice out due to significant body weight loss. So. And then when we looked at some of these tumors under the slide, we saw that triple therapy compared to vehicle and some of the dual therapies compared to vehicle had significantly lower mitoses per 10 high power fields. And so there was also on a cell level, a microscopic, a halt in tumor proliferation. So with a lot of these in vivo experiments, you have to validate with multiple cell lines. And so we did the same thing, a similar experiment with CH157, another immoral cell line. We allowed these to grow again for 2 weeks to about 310 millimeters cubed. The only difference with this experiment is that we increased the dose of bortezomib and romidepsin, just because some of our in vitro data shown on the right here seemed to indicate that CH157 was generally less sensitive to these drugs compared to IOM-LE. And so we wanted to kind of show a similar effect. And so we just kind of bumped the doses of those two drugs a little bit. But otherwise, again, we injected directly into the flank and treated for about 3 weeks. And so with the results here, again, we see when we track tumor size over the course of a few weeks, the combination chemotherapies, especially the triple group, outperformed the vehicle and the monotherapies considerably. And the dual therapies also halted tumor growth significantly, but not as much, and more than the monotherapies, but not as much as the triple. And then again, when we tracked body mass, no significant changes in body mass. So this was, again, very promising and kind of confirmed to us that these mice are able to tolerate these local injections without a lot of systemic toxicity. And then when looking at the CH157 tumors under the slide, we found that, and with a one-way ANOVA here, no significant difference, but some of the pairwise comparisons here with mites were significant, especially between vehicle and triple. So with those first results in, we wanted to see if we could augment the effect of the local chemotherapy with local radiation therapy. And so this was our first experiment with CH157. It seemed like when we added radiation therapy, there was no significant difference when you compared the triple plus RT group and the triple group itself. We think that perhaps the RT regimen we used was a little subtherapeutic, and we are considering future experiments where we increase this dose. And also, we're currently in the process of looking at radiation-associated DNA damage, and looking at those markers to see if there's a difference beyond just gross volume. So some of these results are still preliminary, but what we've shown so far is that combination chemotherapy has significant effects on tumor growth compared to monotherapies and vehicle control in a heterotopic meningioma mouse model. And we're able to show this with some of our body mass that, local flank administration often circumvents systemic toxicity. So kind of where are we trying to go short-term and long-term with this? So we want to also characterize viable tumor versus tumor necrosis, because that's not exactly captured when we just look at tumor volume. And so our plan is to use artificial intelligence, specifically a program called QPath, or quantitative pathology, which can load slides in via a scanner, and we can analyze on the computer, and it can count specific amounts of tumor cells, and we can actually see how much of the sample is necrotic versus not in an objective manner. We also want to do caspase staining for apoptosis, and as I mentioned before, some RT-associated DNA damage markers through immunohistochemistry. So where are we going long-term for this? So if we're able to, with these preliminary results, are the sort of next step is development of a bioresorbable compound in vivo, where we can put a sort of disc device into the flanks of these mice and have it time-release chemotherapy. And our goal would be to show a similar effect that I showed in the previous slides. And if that were to work, we would move into an intracranial model, where we would time release some of this chemo in the brain. And so that is sort of to set the stage for a future clinical trial, where in patients, especially in patients with higher grade meningiomas that recur often, we would be able to implant some sort of bioresorbable compound in the resection cavity to help target microscopic residual disease and decrease risk of recurrence. So that's kind of where we're thinking long-term, years down the road. And so these are some of my acknowledgements. I'm very grateful to the Horbinsky Lab for their support, and of course the Brain Tumor Institute and the Department of Neurosurgery at Northwestern for their funding support and other mentorship and so on. So thank you. And with that, I'll take any questions if there are any.
Vineet, thank you very much. Excellent. Well done. Any questions? All right. Without further ado, last but not least is Ian Ramsey, who is from the University of Miami, and he is both a Doctor of Medicine and a Master's of Public Health candidate for graduation next year in 2024. He did his undergraduate at Bates College in Lewiston, Maine, where he was a member of the crew there. Any fun facts about you, Ian?
Thanks, Dr. Ellenbogen. You took my rowing fun fact. So I would say previously in Andorra and Slovenia, I tried to climb the highest peaks in those said countries, but was limited by snow. So I'm looking forward to increasing my mountaineering skills. So hopefully that doesn't happen again. So let me just share.
Great. Were you lightweight crew at
No, they only had, sorry, can you see my slides?
Yeah,
they only had one class. It's like kind of, although rowing is not a technically an NCAA sport, it's like sort of like Division III. But yeah, no, we only had one weight class. I can't say I wasn't quite as accomplished as Max athletically, but I did my best.
all good.
So,
all good.
Yeah. The title of my talk is the use of big data to assess neurosurgical trends and outcomes during the COVID-19 pandemic. So Dr. Ellenbogen kind of went over a little bit about me. But when I started medical school, it was during the COVID-19 pandemic, and that really limited a lot of the kind of in-person things that were necessary for research. And so given my interest in public health, big data, statistics, I decided that I would start doing some, retrospective database analyses as a kind of a means to do research with slightly limited in-person activities. And so I came across the Nationwide Inpatient Sample NAS database. And so this is a stratified sampling of all inpatients in the United States that's really designed so that we can, look at inpatient utilization, cost, quality, outcomes, kind of in a nationally representative way. And this database contains demographic information, ICD-10 diagnostic and procedure codes, and then some basic outcomes like hospital mortality and discharge disposition. So the first project I'd like to talk about, we recently published in JNIS, is outcomes in patients with large vessel occlusion strokes undergoing mechanical thrombectomy with concurrent COVID-19. And so previous reports have shown an association with between COVID-19 and stroke. And a prior study showed that when these patients do get thrombectomy for LVO strokes and they have COVID-19, they have worse outcomes than those without COVID-19. And so we wanted to further investigate this question. So using the NIS database, we identified patients with large vessel occlusion strokes undergoing thrombectomy with patients that had an ischemic stroke diagnosis, but then also a procedure code for thrombectomy. And of course, we restricted it to 2020 to look at the first year of the pandemic. And so we use a logistic regression multivariate model to determine odds ratios for outcomes for patients with COVID-19. And so what we found, about 17,000 patients overall, but only 380 had the co-diagnosis of COVID-19. And the COVID-19 cohort was younger, about 64 years versus about 69 years in the non-COVID cohort. And this COVID-19 cohort had high rates of diabetes, coagulopathy. About 22% died in COVID-19 group, but only about 10 in the non-COVID-19 group. The odds ratio for death was 2.78, and the odds ratio for routine discharge was 0.65. And looking at some complications in the patients with COVID-19, interestingly enough, we found that there was no difference in cerebral hemorrhage, post thrombectomy, but a lot of medical complications were higher, including PE, DVT, MI, sepsis, and then also the COVID-19 patients had lower odds of requiring a PEG, higher odds of mechanical ventilation. So we found basically that there was a greater mortality and lower odds of routine discharge for patients with COVID-19 that received thrombectomy for stroke in 2020. And we think that it's possible that these worse outcomes may be due to extracranial manifestations, just given the higher odds of many medical complications, but for example, no increased odds of cerebral hemorrhage in these patients. And so the next topic I want to discuss is the impact of the COVID-19 pandemic on treatment outcomes of patients with cerebral AVMs. So as of recent, there's been a little bit of a decrease in intervention for cerebral AVMs, but it's really a controversial topic. And a recent study showed that with kind of this reduced intervention for unruptured AVMs, there is a higher rupture rate nationwide, not causal, but the relationship exists. And so we wanted to look at, what was the effect of the COVID pandemic or during the COVID pandemic on intervention rates and patient outcomes for those that had AVMs, cerebral AVMs. So we queried the national inpatient sample from 2016 to 2020. And basically identified patients with a ruptured AVM as having ICD-10 code for AVM plus intracerebral or subarachnoid hemorrhage. And we considered the treatment modalities of surgical excision, endovascular treatment, and stereotactic radiosurgery. And we did a comparison of patients in 2020 to 2016 to 2019. So we found about 14,000 ruptured, about almost 50,000 unruptured AVMs. In this time period, the overall rupture rate was about 22.5. And in 2020, the rupture rate was higher, almost 24 versus about 22 between 2016 and 2019. And the intervention rate in 2020 was much lower, about 13% versus almost 18 in the 4 years prior. And the odds ratio for intervention for 2020 relative to the other years was about 0.7, which was statistically significant. And this is just a graph showing, again, in 2020, higher rupture rate, lower intervention rate. And in terms of the types of treatments for patients that had unruptured AVMs, there was a slight decrease in the predominant therapy, endovascular only, but an increase in dual endovascular and surgical treatment, and an increase in stereotactic radiosurgery. And then we also found that really over these years from 2016 to 2020, there's a monotonic increase in the rupture rate, and then also monotonic decrease in intervention rate. But as you can see, there's kind of this inflection in 2020 of a decreased intervention rate. So in conclusion, there's a decrease in intervention in 2020 for ruptured AVM with a corresponding rupture rate increase. And then in terms of the differences in treatment, we think that possibly the reason that that surgery and endovascular therapy together increased was, it is of course speculative that maybe given the COVID pandemic, there was just a push to get patients, kind of pre-surgical embolization and then surgery just in one hospitalization, so that you're not getting endovascular therapy and surgery in in two separate hospitalizations. And then stereotactic radiosurgery perhaps went up because it's less invasive and more suited to a pandemic emergency. Lastly, I just want to touch on the effect of COVID-19 on pituitary surgeries. And so in the beginning of COVID-19, there was a reduction in transfemoidal pituitary tumor resections because it was thought that the endoscopic endonasal procedures facilitated the spread of COVID-19. And so we just wanted to actually look at this and see if it affected outcomes. So we queried the NIS database from 2017 to 2020 and compared 2020 to those 3 years prior. And so we see that actually overall in 2020, while there was a slightly lower intervention rate for patients with pituitary tumors, intervention being open or a transfemoidal surgery, but actually the proportion of transfemoidal surgery went up in 2020, which is a little bit counter to what we thought. However, when we looked on a month-to-month basis, more or less, again, it was obviously higher for transfemoidal, but there was this pretty dramatic dip in April, which was sort of the first wave of the COVID-19 pandemic. And that was perhaps, what explained this anecdotal decrease in transfemoidal surgery during the pandemic. And so there was no difference in death for patients undergoing surgery for pituitary tumors. But they did have a lower, odds of routine discharge and slightly higher odds of any complication or neurosurgical complications. And again, if we look at all these aggregate complications over months, the decreased routine discharge, increased complications or neurosurgical complications, and medical complications were predominantly in the 4th month in April, which is the first wave. Again, as I said, the proportion of pituitary surgeries actually increased in 2020 overall, with a slightly decreased proportional amount in the transfemoidal approach in April. And outcomes were slightly worse in 2020, but most pronounced in April. So again, limitations of this data set, it lacks a lot of clinically relevant data about outcomes. And so it often is more just a broad overview of different conditions. However, this database can be good at looking at nationwide trends in neurosurgery in terms of outcomes and utilization. So I just want to acknowledge a kind of large team of mentors and collaborators, but particularly Dr. Evan Luther, who just graduated residency this year and has been a tremendous mentor to me. I'm very, very grateful for all of his support. So thank you. If anyone wants to contact me, here's my email.